There is an assignment that's going to be due next Thursday, and that is the audiogram interpretation assignment. I've already uploaded it, but it's time sensitive, so it will suddenly appear sometime between now and midnight. I forget what time I set it for. So you'll just need to print it off because you do have to draw in some pictures. So print it off, and then you can either scan it and email it to me, or preferably just get a hard copy. Because sometimes, because the audiograms are somewhat smaller, they don't scan real well. So I really worked hard to make it very legible for you, rather than some classes. Hard copies probably best. But you'll feel very confident in doing that after today's presentation. We left off talking about the assessment process, and we talked about the battery approach and how we typically like to include both objective measures and behavioral measures. And as someone pointed out, the main reason why we like to include objective measures, besides just giving us an extra cross-check and vote of confidence in our results, it does take out any of the guesswork, and it does take out any patient factors, whether it be cognition, whether it be motivation, what have you. So typically, we're going to have this battery approach, and the battery is somewhat different for children versus adults, and we'll talk about why that is. But for adults, typically an assessment is going to include otoscopy, which is, know what otoscopy is. There's otoscope, that's the ear light that's looking inside. Why is that something that we would routinely want to do? Health of the eardrum, the integrity of the ear canal. The first time that you use that and you see a bug crawling towards your light, because bugs usually go to the light, it's a little disconcerting. Sometimes you find other foreign bodies in there. I've seen a number of critters, though. Sometimes wax. The ear canal is blocked with wax. That's kind of important to know going into your assessment. So otoscopy gives us a nice visual representation of what's going on inside the ear, at least in the outer ear. Maybe the person has a big perforation or tear in the eardrum. Kind of important to know. So we do tympanometry, which is a procedure that assesses the mobility of the eardrum. And there are basically two things that could affect the mobility of the eardrum. What would those be? Fluid, so the presence or absence of middle ear fluid. What else? Well, the pressure is going to be that certainly it's going to tell us where the peak in mobility occurs. So you've all had that experience where you're like, oh, I just wish my ears would pop. That's because the pressure's out of whack. So that tells us the eustachian tube is not doing its job. But that may affect mobility a little bit, but it's more if there's fluid or not for one other thing.
With an increase in ossification?
Right, so the integrity of the bones. Yeah, you could have calcification or ossification of those little tiny bones, so they're not moving as much. We see that like in Meniere's disease. But you might also get a really floppy response because maybe those bones have been broken or the joints have become disarticulated. What might cause that?
Ear infections?
That usually isn't going to cause disarticulation.
Trauma?
Trauma, yeah. Someone gets whacked upside the head. I can't tell you the number of child abuse cases I've identified or helped identify through that, and domestic violence cases. It's very, very common. Someone get whacked in the ear and it can perforate the eardrum and or can cause the ossicles to become, call it disarticulated. But there are other things that can cause it too. Barotrauma, if a person is scuba diving and they either submerge or re-emerge too quickly, that can cause it. Even folks have been known to get that type of traumatic injury from air flight. So there's lots of things, but anyway, tympanometry helps us, it provides us with three main measures that we're concerned about. It provides us with the ear canal volume, so how much space is there from basically here at the outer entrance down to the eardrum, so that's the volume. And there are normal ranges. So if you get this exceedingly large volume measure, you know that you're dealing with an open system, so probably there's a tear or an opening in the eardrum. So you're not just measuring from here to the eardrum, but beyond in the entire middle ear space as well. So that's important to know. Also, if you have a really tiny ear canal volume, you may actually have the probe pressing up against the side of the ear canal and not actually measuring down inside. So that's an important measure. We also want to know what the middle ear pressure is. So we are very close to sea level, relatively speaking. So we would expect 0 altitude. So we would expect to see that pressure level to be somewhere around a 0 where we get the peak. And there's a normal range. And pretty much, if you get much beyond about negative 150, negative 175, or worse, then you have negative pressure in the system. And that again tells you eustachian tube may not be working well. And then the third measure that tympanometry provides us that we're concerned about is the compliance. How much mobility is there actually taking place? So that we know, is it shallow, meaning that maybe there's fluid, or maybe there's some stiffening of the bones, or is it normal, or is it hypercompliant, telling us that either we have a really scarred, damaged eardrum that's really floppy, or that perhaps there is some disarticulation of those bones, allowing the eardrum to just kind of flutter. So, but it's a good measure of eardrum integrity as well as gives us some indirect information about middle ear function. Okay? Next thing that we want to do is acoustic reflex testing. What that does is when we present a loud signal to the ear, everything is working the way that it should. So hearing sensitivity is normal, if middle ear function is normal, and if neurological function is normal, we should see a very robust reflex. What happens is when your ear is exposed to loud sound, so when the vibrations are strong and forceful, there is a reflex, a protective reflex. The tensor tympani muscle will contract, and it basically stiffens the system, and as a result it kind of squelches that sound. So that when we're exposed to really loud sound, that reflex should kick in, and what it does is it's a protective response. It's not going to eliminate the noise or the loudness, but it is going to minimize the potential trauma through those ossicles. And if it's absent, that gives us information. Or if it's elevated, or if it's abnormally low. I feel, and not everyone does, this is my battery, this is pretty much what our faculty and staff here at Miami use. Not everyone does acoustic reflexes. They feel like, I think it's really important, particularly if I'm assessing babies, and particularly if I'm assessing someone that we suspect might have auditory processing difficulties, because it is truly a measure of the integrity of the auditory pathways, part of them. And so if we have abnormalities there, that can be really revealing. One of the most common complaints that we'll get from folks who have an auditory processing disorder is a sensitivity not just to noise, but actually to sound in general. They may have hyperacusis or hypersensitivity to sound. And invariably, when I see a patient and there's a complaint of sensitivity to sound, guess what I almost always find with their acoustic reflexes? They're absent or elevated, so that a sound that you and I may be exposed to that maybe is annoying, but it's not enough to be painful or to put us over the edge, because our acoustic reflex is kicking in and it's squelching it a little bit. They're getting the full force of that because their reflex doesn't kick in until things are even louder. So that loud sounds are truly reaching their ear a little bit more loudly than they are to you and me. So again, it's a really nice diagnostic tool, particularly if you're looking for certain types of problems. Then we're going to do, one for a second, we have one of my best friends' mothers is actively dying in Idaho right now. So we're going to Idaho soon. Sorry, just this is kind of pure tone, Aaron Bone. We're going to do tone testing to establish their thresholds. That's, when you think of an audiogram, when you see an audiogram, that's what's plotted on the audiogram. So that's when we refer to hearing thresholds, that's what that information is giving us. It helps us to classify or differentially diagnose, is it a conductive loss, is it a sensory loss, is it a mixed loss, what have you. Those speech reception thresholds, that's where the person is able to identify words 50% of the time. That's an important diagnostic tool. It should agree very closely with those pure tone responses. But guess what? People who are malingering or faking the hearing loss, it's much more difficult to fake a loss to speech stimuli than it is tone. Because with tones, you can just completely not respond. Well, you can for speech as well. But I learned a trick when I was doing an internship at the VA, where we suspect that someone may be not being honest about their thresholds. You can present to them swear words, insults, speech stimuli that are not real pleasant, and you can see a reaction on their face if they're really hearing it. They're going to turn red. They're going to start giggling. They're going to be embarrassed. I wouldn't recommend it because we have other ways around it, but back in the day, that was something that we did, and I've been known to, like if I'm testing kids or adolescents, I'll make some comments like, "Oh, your feet really stink. I can smell your shoes all the way over here." Little things like that. And "Oh, did that come out of you?" I'll say things, and you get them every time because they can't not respond. They're going to react to something like that because they're kids. But anyway, it's very difficult to, and if you fake a hearing loss, so say for tones, you don't respond until a certain level, it's really hard to match your response to speech to that same level, and so there's invariably going to be a discrepancy between their speech responses and their tone responses. That's a red flag. So it's a really, and we want to know, are they hearing speech okay? And we really get that by doing a word discrimination test. And that's where we present the word list and then we score how many people get correct. And so we're looking for consistency so that we can then classify what's the hearing like, what's the nature of their hearing. Now, of these, which ones are objective tests, meaning that they don't require active patient response or participation? Trigonometry. Yeah, otoscopy. As long as they don't pull away and cover up their ear, but yeah. So it is what it is. And the acoustic reflex. It's either there or it's not. Yeah. The rest of that battery is considered behavioral, meaning that we're relying on their behavior, their participation in order to get the results. Okay? So that's typical. Now, if we suspect specific problems or the history will dictate it, we may do additional tests as well, but this is pretty much the classic standard adult battery. For pediatrics, we do those same things, except that we add a couple of things where we may need to modify our procedures. One thing that I always do, now not all of my colleagues do this, but I'm the one that sees the most kids. They refer almost all the babies and the kids to me, because most of them would rather not deal with it, and I love it. One thing that I add in is otoacoustic emissions. And that's where we put a little probe in the ear, put in a sound signal, and then we listen through that probe for echoes of the sound that come back. If we get echoes within a specific normal range, then we know that the inner ear is working just fine, and the hair cells are intact, and we can assume that they're hearing normally. It's a test that we do to screen or to check the hearing of infants. So it's a very valuable tool. I also include that in my auditory processing battery because one of the biggest complaints that you get in folks with auditory processing disorder is that they have difficulty with understanding speech, particularly in noise. And if we have damage to those hair cells, what can often happen is the threshold, if they're just damaged but not completely obliterated, we may actually see a pretty normal threshold to tones, but we see a dramatic drop in speech understanding. So I like to include OAEs in my auditory processing battery because if I have this normal looking hearing, but I'm having horrible speech understanding scores, it's not at all unusual for me to see damage there. I also will include that otoacoustic emissions if I'm monitoring a patient for potential ototoxicity. People who are receiving chemotherapy, people who are on aspirin therapy, certain medications are toxic to the ears. Well, typically we will notice changes in their otoacoustic emissions before we actually notice a loss of threshold sensitivity. And so if we frequently check their otoacoustic emissions, we can advise their physician as to the potential need to change or modify their dosage in order to preserve their hearing. Now, granted, for most people, if the choice is use this medication regimen and live, or don't and die, but using it and living may cause you to be deaf, most people are still going to choose to live and have the hearing problem. But it's nice that we have a tool that allows us to monitor what's going on before it becomes so severe that we have a permanent hearing loss. So OAEs are very valuable. They just give us additional information, and particularly for the little bitty guys, they don't have to do anything. And yet we can do that test, and if it's normal, and otoscopy look good, and tympanometry look good, and acoustic reflexes look good, and now we get normal OAEs, guess what? With a baby under the age of 6 months of age, I'm stopping there. I have enough information to feel very comfortable that things are normal. When they get a little bit older, so they get above 6 months of age, I'm then going to start doing some of these additional tests. I may use VRA, which is visual reinforcement audiometry. For any of you, a couple of you, I think, have been with me when I've done that, where the child or the baby is sitting maybe with a parent or by themselves in the chair, and I start putting sounds and tones in through the speakers, and I watch for them to react and respond. That's visual reinforcement. So what happens is I present the sound, they react, I make a toy light up and they make sound. So I'm reinforcing them so that then every time they hear that, they're going to know to look. And so I can get softer and softer and have an idea what their granddaughters are like. Core is a very similar type of procedure. I don't use it. Most people don't anymore, but you may still see references to it. But it's an ocular response, and basically, if you have a kid who maybe has very poor head control, or maybe there's some cognitive issues, and maybe they won't turn their head, but you may see a shift in their eye gaze in the direction of the sound. If I'm desperate, I will rely on that response, but it's been proven over time to not be the most reliable. So, but we can use that ocular movement. Conditioned ocular response, I believe, I don't even remember. I know it's ocular response, I can see this condition. Where basically you do the same thing that you do with VRA, but rather than looking for them to turn their head, to localize to the sound, you see a shift in their eye gaze. Then when they get a little bit older, we can do what's called conditioned play audiometry. And with that, we'll move away from the speakers. Because the drawback when we're using speakers is that when you see the results, my results will always say in the better ear, because you're really only going to get a response to their better ear. They could have one ear that's completely dead, not responsive, and they'll still look in that direction. Eventually, the head shadow effect is not that strong. They'll look over there. And so you can't assume. Now, if you notice that they're responding rapidly, consistently to sounds in both ears, you can feel pretty comfortable. It's probably symmetrical. But unless you've done something like otoacoustic emissions, acoustic reflexes, things that suggest that the same thing's going on in both ears, you really only can legitimately say that you're getting a response through the speakers from their better ear. It's the better ears when it's kind of fine. So then we can move to conditioned play audiometry, and that's where we use either headphones or ear inserts, and we'll give them something like a puzzle or some blocks or some Legos, and we train them that every time they hear a sound, they stack another Lego on it, or they drop a block in a bucket, or they add a piece to the puzzle, or they take a piece off of the puzzle, so that they're playing and they're learning that every time they hear a sound, they perform something for us. And it makes it fun. It makes it like a game. And then eventually, when they get older, we can just do traditional air and bone conduction testing with them, where they press. We typically have them press a button. Some people still have them raise their hand. But especially kids nowadays, they're so used to pressing buttons their entire life, they like that. And what I will often do, I don't do very much conditioned play. Typically, I find they're old enough to do that, especially with the button. If I make it a game, they can do it. So I'm like, okay, you are a superhero. And every time you hear one of those sounds, you gotta zap it before it can, attack the city or whatever. And I've been known to even put like something there, for them to focus on. You want to keep it from blowing up the teddy bear or whatever. And it's amazing. You either have a really sick and twisted kid that you got to worry about who's going to just not do it because that bear explodes, or you see a kid who's, man, they're not going to miss a single one. So But in any case, we can use traditional methods. I can add it and try and make it a game. So typically, I will do VRA up until they're about 3 to maybe 4. And as soon as I feel comfortable that I can get them to respond, I move straight to traditional. The whole condition play thing, to me, as often as not, it becomes a distraction. And then I just start randomly forget it. But if they know they have a mission to save the teddy bear, to save the little fluffy dog, they're more likely to cooperate. Anyway, then if they're really little and they're not necessarily able to repeat the words, I would do a speech awareness test where I'm just basically waiting for them to say something and return to what I say, because I'll do it. We're going to play a game. I say it, then you say it. So every time I say something, you say it back to me. Well, if I get a response back when I've said something, I know that they're aware of my voice. They haven't necessarily recognized the speech, or their speech may be so impaired that I can't understand what the flip it is that they're saying in response, but at least I know they heard it. So I get an awareness level as opposed to a reception level. And if they're able to repeat, or I can actually say, and they can point to pictures. We have a test that has picture templates where there's like 6 pictures on a page. I'll say the word, they point to what it is that they think they heard. So again, we can do that. I will use speech even with my littler guys, just because where I'm using the sound field, because I want to see, is their response to speech similar to their response to localizations to the sounds. And then, again, if they're old enough, I'll do word discrimination. That can be difficult, somewhat unreliable, because a lot of times when you're testing a kid, the reason you're testing them is because they have a history of middle ear problems, and they want to, or they're wanting to rule out as their hearing loss because their speech and language isn't developing. And so this is where I think I'm a better audiologist than some people, because I'm also a speech pathologist, and I can recognize the phonological errors that they're making, and so I can realize, oh, they have velar fronting. So every time I give them a k or a g word, I get a t or a d word in response. I'm going to count that right. Not because it's not that they didn't hear it. They aren't. They have a phonological problem. So, but I'll make mention of that. That their speech or their word discrimination scores were blah 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 when accommodations were made for their obvious articulation or phonological errors. Just so that people, because I've had people say, how could you like, especially the people at Children's, they think that they're the be all end all. They say, we never get more than like 76, 80%. And I was like, well, are you taking into account that this is a kid that deletes all their final consonants? No. Well, I do, because I recognize that. And you know, I mean, if it's if you can figure out what the flip they're saying, and you know they're saying what you just said, they just have a speech problem, I don't count it wrong. Anyway, so that's the pediatric practice. So it's a little bit more involved, depending on the age. Really, pretty much, once they get above the age of 4 or 5, the battery is almost identical, other than that I always include acoustic emissions kiddos, just because I want to have that extra level of objective data. Sound field. That's the speakers. So we're putting the sound into the speakers, and if you notice, the speakers in a test tube are always angled in the corner. So what happens is the sound is bouncing all around. So we call that the sound field. And we sit them right square in the middle, so that they are truly getting the effect of that sound bouncing around. Good question. Thank you. Sometimes we'll use terminology or abbreviations, and if you don't know, please ask. And audiologists are really notorious for that. Like, we'll throw out things like OADs and DPOADs and ADR and things like that that we know, that you guys may or may not know, so don't be afraid to ask me. Because I bet there are 6 other people who are wondering the same thing. Okay, so when we test a patient, we are going to plot their results on an audiogram. And audiogram is basically a way to graphically represent their hearing thresholds. Across the top, so on the horizontal axis, we have pitch, frequency, tonal quality, whatever word you prefer. But it's the frequency of the sound. On the vertical axis, we have the intensity, the loudness. Okay? So the lower you are on the page, the louder the sound was before they heard it. And moving from left to right, we're going from lower pitches to higher pitches. Okay? Make sense? We represent air conduction responses with X's and O's. Remember, the right ear, red is round, and it's right. So if you remember, for the right ear, it's red and it's round, you'll never be wrong. Right, red, round. The left ear, air conduction, we use an X, and it may be blue. I personally do not care if you color code them on the audiogram or not, because more often than not, when I get a report, it's a photocopy, and most people are not going to print it or copy it in color. So just know that round is right, and X is left. For bone conduction, which is a measure of the cochlear response, it's represented by the little brackets. And what I learned is, okay, if you're testing a patient, you're looking at them, so your patient is here, smiling back at you. Okay, here's his little ears. All right? Look at them and go like this. Okay? Now we got to turn it around. So where's their left? It's over here. Okay? So we actually marked it downstairs. It's on the wall, in case you're wondering. So that you know left, right. Okay? So that you know which way, if you can't remember, just draw your little person, and rather than drawing ears on the little brackets, and you'll know which one is which. Thanks, Dr. Hahn, that's clever. I never would have thought of that. Okay? So, again, our X and our O is for left and right. We will use a square if the threshold required masking. What's masking? Where? In the other view.
Oh, right.
Why?
Right.
And why would we do that? Right, there is a thing, a phenomenon where, because sound is waves, sounds produce vibration, it is possible that when presenting a sound to one ear, it could be, if they have hearing loss there, you could be presenting it at such a loudness level that it causes vibration that is then picked up by the other ear. So basically what you're doing, there's a discrepancy between the ears. You are simulating hearing loss in the non-test ear to make sure that the response you're getting is really from the ear that you're testing. Now I can tell you that crossover phenomenon, that's what's called as crossover. That'd be a good question. The non-test ear responds to the simulation to the test ear. Theoretically, crossover can occur when the difference between the ears is as little as 40 decibels. I can tell you in the years of testing, I have never met someone who had a crossover level of 40 decibels. The smallest I've ever seen is 55 decibels, but the research suggests that it can happen at that level. But guess what? That research was done when we always used earphones that sat on the ear. Now, most of us, I always, use ear inserts. They're foam, and they go inside the ear, so there's not nearly as much surface area to vibrate. And guess what? Inserts are foam. What does foam do? It absorbs vibrations. Why do we put foam, little things, when we send fragile things through the mail? To absorb the vibrations. So guess what? Chances are, somewhere between slim and none, that unless you have a pretty much dead ear on one side and a fairly normal ear on the other side, that if you're using inserts, you're going to get that crossover, but we still mask to make sure. We're all about covering our butt. So if we masked the presentations in the left ear, it's a square. If we masked a presentation for the right ear, we use a triangle. Why do we do that? Because if I have made these thresholds in the left ear, and now I test the right ear, and they're way up here, I'm going to need to go back and retest that with masking. Well, guess what? A square goes very conveniently around an X, so that if it's there, I know. The flip side is, if it's the right ear, a triangle fits very conveniently around a circle. So it wasn't, there was someone we could way back there. So that's why the triangle and the square, because the unmasked will fit inside. If we have masked bone conduction, because we may have to mask for that, we would use that type of bracket. And again, you can draw your ears on, and you know which side to put it on. Okay? I'm not going to worry much about these others because, well, I'll go over the sound field. But we typically don't use forehead placement for bone conduction. We just, you want ear-specific information each one, so we don't typically do that, so I'm not going to worry about it. You don't have to worry with it. If we use the sound field, what people will typically do is do an X with little hash marks on it. I don't know if you can really appreciate that, but it would look like that. And if you do in the right sort of like the do not symbol. But again, more often than not, you cannot be absolutely certain as to which ear is responding unless you know you have a dead ear, for example. So we will typically use the S, meaning it was a sound field threshold. Okay? Most of us do not put our acoustic reflex thresholds on our audiogram. That's an old-fashioned thing that we typically don't do, so don't worry about it. Don't worry about the forehead placement for bone, and don't worry about the acoustic reflex thresholds. Because if we've done acoustic reflex thresholds, you're going to see a section on the audiogram that lists that separately. So my feeling is if I'm telling you what it was, why am I going to make an extra mark on the audiogram? Yes?
I forget with masking, are you putting the symbol on, that was what you used like the ear that is something to, do you understand? Or is it the test ear? And then we have
Yeah, okay, that clarifies. You always, the symbol represents the test ear. So, in this case, that's a good question. Let's clarify that because you need to know. All right. So we're testing our person here. All right. So here's his right ear. Here's his left ear. Let's say that we are suspicious that maybe this response in this left ear is not normal or is not accurate. Okay? We're going to put masking in the right ear, and we're going to measure the response for the left ear. So, when we get the response that we feel is legit for the left ear, we're going to use that left ear symbol. So your symbol always represents the ear that you're testing. Does that make sense? So match your symbol to the ear that you're testing, regardless of whether you're using masking or not. Masking is only going to determine which symbol you use, but you're always going to be using the symbol that corresponds to the ear that you're testing. Make sense? Maybe?
Well, then you just have to decide if you can cross over through the ear.
Or both. Because you will frequently end up with something that looks like this, or something that looks like that. Because you may have to mask for both. Right?
Why don't we just mask in the first place? Why don't we just mask in the first place?
Because it's an extra step and it can be really confusing for some patients. Because I will tell you, what we typically do is what's called a plateau method, where we start off with a minimum amount of masking, and then if the person responds, we increase the masking again to make sure that the person responds, and then we'll increase it a third time to make sure that they're still responding. Because what you might see, especially if there's a big discrepancy, is every time we increase the masking, the threshold shifts. We increase it, the threshold shifts, then we know we have a masking dilemma. That the minimum amount of masking needed is too much and the other ear is responding. So, and what I will invariably see, because I always wait, so why do you wait? I'll increase the masking, so I got a response, and okay, so I'll increase the masking, and then I wait. And then I present again, because invariably, as soon as I increase the masking, they hit the button. And like, okay, what are they responding to? So I'll wait Then I present it, and if they then press their button, then I know, okay, they really did hear what I just put in. For you guys, you're all intelligent, bright, probably cooperative. It wouldn't be an issue. But I don't have the benefit of knowing that much about a lot of my patients, and so I have to assume that I may be overwhelming them. And quite often we are. So it's just an extra step, and you have to sit there and do a quick, calculation, and you also run the risk if both ears are doing the same thing of if you advance them into the other ear of it causing indetectable testing. So you only want that when there's a big discrepancy. Good question. Very good question. But that's why we want to reduce the number of steps involved, and we want to minimize the risk of using our okay? So, once we have plotted out our patient's hearing levels, we have to make a statement or provide an impression about their results. There are different ranges of hearing sensitivity for children versus adults. Why? Exactly, they're learning language, and so even a small amount of hearing loss.
Because if I'm feeling cold and I'm suffering off this and my voice is muffled, I bet at least those of you who are top can understand everything I'm saying.
Because you're adults and you've mastered the language. But what happens
if I'm talking like this to a little kid who has a limited vocabulary and is just learning public talk?
He's not going to understand what I'm saying. Or if he does pick up on what I'm saying from the context, which often happens when he tries to talk, gee, why does Johnny sound, and say, they sound like they're mumbling. Well, yeah, because
everything the computer sounds like it's mumbling.
Okay? So, the biggest reason we want them, as Grace said, we want them to have some access to sound. Absolutely, they need to be able, but the root of it is because even a minimal reduction in sound sensitivity can be devastating for a child's potential for learning language and other things. So, the range of what is considered normal is more restrictive for children than it is for adults. For children, any threshold better than 15 decibels is normal. If we're between 16 and 25 decibels, we will describe them as having minimal hearing loss, or sometimes you'll see the word slight. But minimal is what's used more often. Whereas with adults, we say that normal goes up to 20, that borderline is 21 to 25, and then beginning at 26 decibels, they're the same. Now, many people, especially old school people, will say that the normal range for adults is up to 25. I don't buy that. And when I was in school first time and had my master's, we set up to 25. When I went back to school and got my doctorate, and we actually were studying more of the literature and more of the research and actually doing advanced testing, it made sense to me because I will often see people in the office whose hearing is at 25 decibels and they're freaking because they're having trouble, particularly with discriminating. So I do go by that 21 to 25 dB range in adults is borderline. I'll refer to it as that in our report. But then, once we get above 26 or above, the ranges are now the same for each, okay?